Hey everybody, I'm very, very sorry that we don't get to do this in person. I know this isn't probably the way you guys saw your semester ending either, but we will keep on plowing ahead despite the crisis, and hopefully I'll see you guys sometime next year when all this is blown over and we're able to kind of figure out what the new normal is going to be as this thing comes around every so often. That being said, let's talk thorax and keep you guys on track and ready to go help out. So, should look very familiar. The bones of the thoracic wall are going to be our vertebrae and ribs, and we've actually seen most of those already. So refamiliarize yourselves with the generic features of the vertebra. And a couple things to draw attention to specifically for the thoracic vertebra. Just to reiterate, we have the facet for the head of the rib present from T1, and then we have a little bit of a break, and then from T9 to T12 we have a single facet for the head of the rib on those vertebrae. Everywhere from T2 to about T8, however, we have demifacets. So a single rib head will be shared by adjacent vertebra in the thoracic region as well as their intervertebral disc. And so those half facets are called demifacets. And don't forget that we've also got on many, but not all, the of the thoracic vertebra, the transverse costal facet, where the tubercle of the rib will articulate and actually forms a nice little synovial joint right there. So let's talk about the ribs themselves. We're going to have the costal head, kind of an enlarged area that's going to articulate with the vertebral bodies, a narrower costal neck, and then a pretty expanded tubercle, large area for muscle attachment and also with an articulation for that transverse costal facet. Now then, we get to the body of the rib, this long stretched out portion here. On its internal or medial aspect, there's actually a groove on the medial underside or medial inferior side. That costal groove is a place where the intercostal vein, artery, and nerve tend to be stuck so that they can be protected from outside pressure. So right there, costal groove, is where you'll find those. The ribs do not all look the same, and if you're able to get access to a skeleton or a half skeleton where you're at, hit the museum if they're open, or you can do a virtual tour. You can check out how the differences in these ribs actually are apparent. Ribs 1 and 2 are very squat and flat. They're not very long because they're just at the upper part of the thoracic cage. Then 3 through 10 are more what we'd think about as traditional ribs. They're expanded out with a nice little curvature making up the thoracic cage. And then 11 and 12 are called floating ribs. Now they're called that because unlike the other ribs 1 through 10, they do not connect to the sternum. So now let's talk about the sternum itself. When we say sternum, we're almost always talking about the entire bone sitting on the anterior side of the chest, or the breastbone, but in reality it's made up of 3 bones that more or less fuse. The manubrium, the large superior part, the body of the sternum here, and the xiphoid process, which begins mostly cartilaginous but does ossify as we get older. The manubrium and sternum actually share a synovial joint. You can see that represented right here, and I know this from first-hand experience because I made mine pop one time and it hurt like crazy. But that's what we've got there. We've got an articular site for the clavicle here, and then ribs 1 are going to articulate with the manubrium. Rib 2 is going to articulate with the manubrium and the body of the sternum. Then 3, 4, 5, 6, 7. Those ribs articulate strictly with the body of the sternum itself, getting closer to the xiphoid. So another way we can break down the ribs is whether or not they attach to the sternum directly or through an intermediary. So all ribs have a costal cartilage extending from their body to reach the manubrium or the sternum. So the bony ribs do not directly make it there. There's cartilage right there that actually makes that span, and that's costal cartilage. And ribs 1 through 7 have their own individual costal cartilages that make it to the sternum, but then ribs 8 through 10, their costal cartilage joins the costal cartilage above it to eventually make their way to the sternum. So because of that, they're sometimes called false ribs, which I don't really care for the terminology, but they are sometimes called that. And ribs 1 through 7 are called true ribs. And then 11 and 12 have little tips of costal cartilage on their ends, but they do not make it to the sternum, nor do they make it to the costal cartilage of their neighbor. Now, I mentioned earlier that we've got the clavicle articulating with the superior lateral aspect of the manubrium, and if you ever get a chance to check this out on a skeleton, look at the articulation. It looks terrible. It looks like there's no way those two bones ought to actually intersect together. The reason it works is because there's a very thick, strong joint here. So the sternoclavicular joint is very tough, and within it there's an articular disc, or at least a little articular meniscus, that is going to actually keep those two bones articulating together in a roughly approximate way, but that's not represented on bony skeletons that you actually see. So we've got that. We also have a nice tough costoclavicular ligament stretching between the first rib and the inferior side of the proximal clavicle, and for good measure we have the subclavius muscle, which we mentioned in the upper limb, going from the first rib also to the underside of the clavicle. And these are going to be very helpful in clavicular fracture, in preventing it from distracting very far, since the clavicle is very frequently lacerated, or not lacerated, fractured. So let's return to the vertebra and the ribs now. Now, I'm not going to ask you to identify any of these specific costotransverse ligaments. I just want you to know that there are a variety of ligaments tethering the transverse processes of the thoracic vertebra to the ribs. So there's a lateral one out here coming off the transverse process to the posterior side of the rib. There's a transverse or costotransverse ligament here running along the anterior side of the transverse process going to the tubercle and neck of the rib. And there's also a superior costotransverse ligament going from the rib to the adjacent superior transverse process. So I just want you to know there's a variety of costotransverse ligaments. The one I do want you to absolutely know is the ligament that fans out from the head of the rib onto the facets or demifacets of the vertebra and the adjacent disc. So it's been cut here, and you can see that radiate ligament of the head of the rib really helps keep it in place. And if anyone ever talks about having a rib out, the rib does not move grossly, but it can sublux out of this joint and put some stress on that radiate ligament of the head of the rib. And if anyone's ever had that, you know just how irritating and painful it is to breathe with that rib subluxed slightly out of place relative to its facets. So now, let's take a look at the rib cage from a variety of views. Oops, pardon me. Had a little bit of coffee today, so my finger's a little twitchy, and I may advance the slides a little quicker than I expect. Please bear with me. Thanks a lot. So right here, what I want you to note is that the ribs, especially from this lateral view, they're not horizontal. They really do descend in a anterior-medial direction. So they're from the posterior side down, they really do descend. And when you look at the ribs from the front, right here, 1, 2, 3, 4, 5, we can see the fifth rib right here, but if we look straight back, that's not the fifth rib behind it. That's actually, let's see, 6, 7, 8, that's actually the eighth rib that we're seeing there. So just be aware that the ribs in the front and the ribs in the back don't correlate because the rib cage is not horizontal. Now, why have a rib cage in the first place? Mostly to protect the thoracic organs, thoracic viscera, so the heart and the lungs. And because the lungs need to be pumped open like a bellows and pumped closed to expel air in order for us to breathe, the ribs have to be involved with that. Now, first things first, and we'll talk about this in more detail momentarily, the diaphragm is the muscle that does the majority of the change in thoracic volume that allows breathing to happen. So when we breathe in, our diaphragm drops down, the lungs expand, and air is pulled into them. However, our ribs also move and do expand, so that some movement of the ribs is responsible for full inspiration when we're breathing. So when that happens, the first two ribs, they kind of elevate. So they kind of hinge upward, so the anterior part of ribs 1 and 2 kind of moves superiorly, whereas ribs 3 through 10, because of their long extended body swaying out to the side, they tend to expand in what's called a bucket handle motion, meaning they go from a lower area, and when we breathe in, they elevate up here, kind of like the handle of a bucket. And that's going to expand the thoracic cage out laterally. And if you want to, just take a deep breath with your hands on your rib cage. I'm doing it now. At the limit, before you're done breathing in, when you reach the limit, you'll feel those ribs move up. Now, 11 and 12, being floating ribs, they can't swing upward. They more move like pinchers, and they just kind of hinge at their costal heads and move laterally to accommodate that change in dimension. So basically, all that's happening at the same time during deep inhalations, and because the sternum is tethered to the ribs, it's going to move also. It tends to elevate a bit because of ribs 1 and 2, but it also tends to move anteriorly as the bucket handle motion of ribs 3 through 10 takes place. So take a moment and palpate your sternum and take a deep breath out and in, and hopefully you'll feel it move a bit anteriorly at the very end of your inhalation there. And if anyone's feeling lightheaded, take a moment, pause, and we'll come back. So we've got a lot of bones. Now we need to add the muscles. And the good news is we've seen a few of them before, because muscles of the thoracic wall, a lot of them are going to be anchoring from the thoracic wall to get to the upper limb, and we've seen those already. So let's take a look here. We've got our clavicle. We've got our 3 parts of the sternum: manubrium, sternal body, and xiphoid process. Then we have our trapezius coming down to attach onto the distal clavicle superior side. We've got the sternocleidomastoid coming down to attach to the superior proximal clavicle and the superior part of the manubrium. The deltoid muscle is extending from the clavicle, the acromion, the spine of the scapula to the deltoid tuberosity of the humerus, and the pectoralis major. Its clavicular head here and its sternocostal head, sometimes called sternocostal abdominal head, is fanning out from all those structures to reach the intertubercular sulcus. Right there, deltopectoral groove with our cephalic vein, right there between the two. And if we take the pectoralis major off, we've got a layer of pectoral fascia, and within it we have the pectoralis minor muscle extending here from ribs 2, 3, 4, and 5, mostly 3, 4, 5, we'll say a little bit of 2 there, and up to the coracoid process. Our serratus anterior attaching to the lateral aspect of the ribs, very big muscle, somewhat covered by the other structures here. And then some muscles we haven't really talked about yet. You'd think that the abdominal muscles, like the rectus abdominis and the external abdominal oblique, would be found in the abdomen, and we'd only talk about them there. But the thing is, those muscles actually originate from the thoracic region, and then they stretch down into the abdomen, and we're going to see a lot more of those in the next part of the course. But just be aware, these abdominal wall muscles take a lot of origin from the actual thoracic wall, and we have to deal with them in the thorax. Now we take a look posteriorly. A lot of these muscles we've already seen in the back. So once again, trapezius, coming from the occipital bone, nuchal ligament, cervical, thoracic, upper lumbar spinous processes, and focusing their fibers onto the spine of the scapula, the acromion, and the clavicle anteriorly. Latissimus dorsi, coming thoracolumbar fascia out to the humerus, teres major from the lateral scapula to the same place. Then deep to the trapezius we have our rhomboids. So they're going to be upper limb muscles as well, found in the back, and serratus anterior, serratus posterior inferior, and external abdominal oblique, as we mentioned before, arising from the ribs and then going to the abdomen thereafter. So the serratus anterior muscle is located on the lateral thoracic wall. Its muscle origin is from the medial border of the scapula's anterior side, and then it fans out across the lateral aspect of the ribs, allowing it to move the scapula around. It's supplied with blood by the lateral thoracic artery off the axillary artery here, and it's going to get its innervation from the long thoracic nerve right here. So serratus anterior is there, along with its neurovascular supply. We also have a nearby superior thoracic artery supplying the upper 2 intercostal spaces, because the arch of the aorta doesn't come up high enough to give off posterior intercostals in this area. So let's talk a little bit about these intercostal muscles. They're located between the ribs, and thankfully, sensibly, on the outside we have the external intercostal muscle. We can see that its fibers are traveling in an inferior medial direction, and as it reaches closer and closer to the sternum, it actually gives off a fibrous membrane, the external costal membrane, that actually makes it to the sternum. If we look at the posterior side, we can see these external intercostal muscles, they actually make it all the way to the vertebra. So even though they don't get to the sternum, they are here from the vertebra all the way around in between the adjacent ribs. And nearby, we're going to have deeper muscles as well. Let's see if we can find those. This isn't the best view, but it's okay. We have external intercostals on the outside, and then on the inside, we have internal intercostals. Now, these are actually running in the opposite direction. Their fibers run in an inferior lateral direction, so perpendicular to the external intercostals. And even deeper yet, we have what are called innermost intercostals. Now, let's back up a minute. The internal intercostals are present along the sternum, fanning out, but they don't quite make it all the way to the vertebra. So a little bit of the opposite of the external intercostal, and I'll have a slide illustrating that in a minute, so don't worry if that sounds a little bit odd. The innermost intercostals are only present in the lateral side of the thorax, so we don't really see them close to the sternum or close to the vertebra. And then last and arguably least, we have the transversus thoracis muscles here. These are fanning out from the xiphoid and inferior body of the sternum to the internal posterior side of the anterior ribs, and they're going to be involved in depressing the ribs during a very forced exhalation. One thing to know about the transversus thoracis is it covers this very large set of vessels on either side of the sternum. This is the internal thoracic artery and vein, and we have to account for it when we're doing bypass operations for the heart that involve these vessels as autografts. So just be aware, transversus thoracis might be a little bit of an issue during those kind of bypass procedures. So let's take another look at the same set of information and see if we can make sense of it. So the external intercostals are the ones that we see on the outside, directed in an inferior medial direction with a membrane anteriorly that makes it to the sternum. We take those off, we then see internal intercostals running in an inferior lateral direction, and they're going from the sternum back, but they don't quite make it to the vertebra. They give off a membrane beforehand. And then the innermost intercostals, still inferior lateral, so they parallel the internal intercostal muscles, but they don't make it to the sternum or to the vertebra, just a thin little membrane extending from them. So I mentioned that the diaphragm is going to be a major muscle of respiration, and it is, and it marks the kind of limit between the thorax above and the abdomen below. So it's actually sealing those two off. But there's a few things that need to make it through, like the aorta, the esophagus, and the inferior vena cava. So we'll see that it's not a complete block. It does have to allow some of those structures through, which can sometimes create some problems. The diaphragm attaches all the way around the thoracic wall, so from the vertebra to the ribs, all the way around to the front, to the xiphoid process, and around the same way on the opposite side. It has to have a complete connection from the body wall posteriorly, laterally, and anteriorly to be sealed off, to be able to be strong and not allow herniation of gut contents up into the thorax. So now that we've talked about that, let's talk about breathing. Now, when we breathe in, that's a very active process, and the major muscle involved is the diaphragm. The diaphragm is a domed up muscle. It domes upward when it relaxes because the abdominal contents are pushing on it. But when it contracts, that dome flattens out, the floor of the thoracic cavity drops, and the lungs expand. So the diaphragm is the major one. Thereafter, the external intercostals are a big help in elevating the ribs. They're going to help pull those ribs up in their bucket handle motion. The peristernal region of the internal intercostals actually helps out with the same process. And our scalene muscles, a group of muscles extending from our cervical vertebra to ribs 1 and 2, are going to help elevate those ribs. So these are the muscles typically involved in normal, non-stressful inspiration, breathing in. Now, muscles involved in expiration, it's a little bit of a misnomer, because if we're sitting here quietly, breathing, not working too hard, largely expiration is done automatically as the elastic content and reticular fibers, elastic fibers in the lungs themselves recoil. And as the muscles that have been elevating the ribs relax, they're going to drop. And as the diaphragm relaxes, it's going to dome upward and push air out of the lungs. So relaxed expiration is actually very passive, doesn't involve a great deal of work. But if you're running really fast and you're breathing hard, you have to push air out of your lungs much faster than it wants to leave of its own accord due to just elastic recoil. So when that's going on, you have to make use of other muscles. And forced expiration makes use of mostly abdominal muscles. Now let's think about that for a second. We haven't talked about the abdominal muscles, so why would they be involved in changes in the thoracic volume? Well, think about the diaphragm. When the diaphragm contracts, it flattens out and it pushes down on your abdominal viscera, your guts. They are being put under pressure. They don't necessarily like pressure. So when you breathe in, you might notice just passively your anterior abdomen expands outward. So if you're not sucking your gut in and you're just kind of feeling your abdominal wall, it's going to tend to expand outward when you breathe in because your guts are pushing on the abdominal wall. But if you tighten the muscles, you're going to put the organs under pressure, and then when your diaphragm relaxes, that tension in the abdominal wall muscles is going to push your organs back up into the diaphragm quickly. So keeping your abdominal organs under pressure actually makes you breathe out quicker as the diaphragm just gets jammed up into the thorax to push air out of the lungs. The transversus thoracis also involved in forced expiration because, as we can see here, its fibers are running this direction and would pull the ribs inferiorly and bring the bucket handles of the ribs down during expiration. So there we go. Internal intercostals on the outside are also going to be another muscle that kind of pulls the ribs down, anchored inferiorly, pulling them down that way. So abdominal muscles that we'll talk about later, internal intercostals off to the side, and the transversus thoracis. When someone has long-standing respiratory problems like COPD or emphysema, you can actually wind up with hypertrophy or overgrowth of some of these accessory muscles of respiration. Now, people with these problems are going to have trouble getting air in and out of their lungs, and so the muscles that move the ribs are going to hypertrophy. Now, the diaphragm might hypertrophy, but we'll never really know because we can't just look at it. But in addition to normal muscles of respiration, some muscles that aren't respiratory muscles get pulled into this, largely because they have some connection to the body wall. So, if I have to move my ribs using my serratus anterior here, or my scalene muscles here, or my pectoralis muscles here, I don't want them moving my arms, I want them moving my ribs. So what someone will do is lean forward, and you can try this yourself. You lean forward, put your elbows on the table, and then you've locked your upper limbs. Then, when those muscles contract, they help elevate your ribs. And if you're out of breath from a run or something like that, and you find yourself leaning forward on your elbows on a table or something like that, it's because your body's telling you, hey man, I need a little help elevating the ribs. I'm exhausted. Let's bring those upper limb muscles into the mix as well. So trapezius, levator, scapulae, rhomboids fix the scapula, and that allows these other muscles to kind of reverse their motion, and especially the serratus anterior, to then work on the ribs rather than the scapula. So look for hypertrophy of these muscles. Now, somebody with long-standing COPD or emphysema will often have what's referred to as a barrel chest. Partially that's because these muscles keep pulling outward on their ribs over and over and cause them to expand out. But a less appreciated reason is that as they lose elastic tissue within their lungs, as the air spaces get bigger and bigger, making breathing harder, their lungs don't recoil like they used to. And so the lungs are actually pushing the thoracic wall outward from within, causing the chest to enlarge as well. So it's kind of a double whammy, causing that barrel-chested appearance for people with long-standing COPD. I should say emphysema shows up a little bit differently, but that barrel chest with COPD is kind of due to hypertrophy of the muscles and lack of elastic tissue in the lungs. Oh, trapezius there, serratus, there we go, all these guys, yeah. All right, so for these questions, just take a moment and read through it. I just let you pause the video, and then I'll come back with the answer. So right here, oops, sorry, thought we had an arrow coming in. So, awkward fall during gymnastics practice. What's going to happen? He has a chest pain and bump on his neck. So, superior lateral border of the nugum on the right side Area sore gets worse when he moves his right limb forcefully. What's been damaged? So what do we have along the superior lateral border of the manubrium? First rib is on the lateral side of the manubrium. Second rib's on the superior, the side of the sternum body meeting the manubrium. Sternum-manubrial junction, not really. That's around rib 2. Like we said before, those two correlate. Xiphoid process is way low. It's actually the clavicle. So this is somebody who's got a clavicular dislocation, or at least a clavicular fracture that's maybe a bit incomplete. All right. So running a long distance, you develop a side stitch. You got pain when breathing in, localized to the intercostal spaces around T4 to T6. So you're breathing in. Which muscle is complaining as it contracts? And that's what a side stitch is. It's a cramp or kind of an angry sensation coming from one of your muscles of inspiration. So, innermost intercostal, I want you to note that pain is in the intercostal space around T4 to T6. If it was really close to the sternum, maybe, but external intercostal is the better answer because it's a muscle that's definitely involved in inspiration as you breathe in. Innermost and internal intercostals, they're more involved in expiration, especially laterally. Serratus anterior, not really going to be one that you get a side stitch in when you're breathing, and thoracic diaphragm is not going to be localized to those intercostal spaces. So external intercostal is the best answer there. All right, we've talked about bones, we've talked about muscles. Now it's time to bring the blood supply into the mix. Now, largely, we've got blood supply coming from our aorta by means of multiple intercostal arteries. You can see them stretching out here and here. Since the aorta is a little bit to the left of midline, the right-sided intercostal arteries are going to travel a little bit further and go in front of the vertebral bodies right there. The skin and muscles in this area are going to be perfused by branches that follow the nerves. So if we have posterior rami leaving the spinal nerve here to the back muscles and the skin overlying it, we're going to have the branching of the artery doing the exact same thing. Now here, the anterior rami, the nerves that are coming around, are going to innervate those internal, innermost, external intercostals. Other structures are going to have themselves perforate through laterally to give off a lateral cutaneous branch, and then keep going all the way around to about the sternum and give off an anterior cutaneous branch. So the nerve and the artery are largely doing that exact same thing, supplying blood to that area, sensation to the skin, motor to the muscles, and anteriorly, I just want you to note that we've got those internal thoracic arteries here, and they're going to supplement the blood within the intercostal artery that's traveling that area. So we have posterior perfusion, anterior perfusion. Sometimes people call this the anterior intercostal artery. Sometimes they call it the posterior intercostal artery. I'm just going to call it the intercostal artery and be done with it. Just know it gets perfusion from anterior and posterior sources. I don't particularly care for this picture, but it's a nice enough cartoon showing that continuity between the internal thoracic artery here, giving off anterior intercostal branches, and the aorta posteriorly giving off posterior intercostal branches, all of which create a network of intercostal artery perfusion through that intercostal space. Now, they're also showing that a little collateral vessel is coming off in the the inferior part of the intercostal space. They're making it look way too big, but that does happen. There is a little bit of a collateral branching going inferiorly there. So from the arch of the aorta, the brachiocephalic trunk is going to give off the right common carotid artery and the right subclavian. Off the subclavian arteries, we're going to have, once I get to it here, that internal thoracic artery right there. Off the aorta, we have multiple intercostal arteries there. And there we go. And then anteriorly, we have the anterior intercostal arteries coming off here and making that network and making a continuous intercostal artery from front to back. Now, the intercostal veins parallel the arteries, but they drain to a different set of vessels altogether, and you probably haven't heard of these before. You've probably heard of the superior vena cava, and the blood from the intercostal veins will eventually wind up there, by and large, but posteriorly on the vertebral bodies. On the right side, we have what is called the azygous vein. The azygous vein receives venous blood, a little bit from the lumbar region down here, but largely from the intercostal veins that are coming into it from the right side. The azygous vein is usually kind of accompanied by a smaller vein on the left called the hemiazygous vein, and it's getting its venous blood from the left side intercostal veins, and then stretching superiorly from that little connecting branch there, there's often an accessory hemiazygous vein that's getting blood from the upper left intercostal veins. So the blood from this system is going to tend to drain to the azygous vein, and from the azygous vein up into the superior vena cava just before it reaches the heart. But it's worth noting that accessory hemiazygous vein also often connects to the brachiocephalic vein on the left side here. So there's a little bit of redundancy and a little opportunity for a flow in multiple directions within this system. But you should know this is the system that drains the posterior body wall, its venous blood, and will also receive blood from some other structures like the bronchi and the airways. Now when we look at the vessels and the intercostal nerves in space, I'm not wild about this picture either, but it'll suit our needs. They tend to go from superior to inferior, VAN, intercostal vein, intercostal artery, intercostal nerve. Now, if I could go back, I'd actually move these much higher up underneath that costal groove. So down here, you can actually see the VAN, the vein, artery, nerve. They should really be tucked up underneath that costal groove right there. We got the external intercostal muscle here, internal intercostal muscle here, and then the innermost intercostal muscle here. And that's generally where you find these vessels, between the internal and innermost intercostal muscles. Here's those little accessory branches that are coming down. We're not going to worry too much about those. We're really going to be concerned about these bigger neurovascular structures on the superior side of the intercostal space, because they're the ones that can be damaged when we do a thoracocentesis. So what that is drawing fluid from the pleural space, or the space that surrounds the lung. So if we have fluid there and we don't want it, we want to make sure we can draw fluid from that area, puncture the intercostal space, but not stick the needle into a big vessel or nerve. So we absolutely avoid, and by the way, here's a much better picture showing it tucked underneath that costal groove, we avoid the area immediately inferior to a rib, because it's almost certain that we'll have those big vessels there. It's a good idea not to go too close to the superior border of a rib, because those smaller collateral branches are there, not as big, but you generally want to try to put the needle right in the middle of an intercostal space whenever possible. And if you're trying to actually perfuse that area or put some anesthetic into that area, you might want to get a little bit closer to those intercostal nerves to anesthetize them. Now, we just talked about drawing fluid out of the pleural space. What is the pleural space? Well, it's the space that surrounds the lungs, and we have a pericardial area around the heart. Now, the thorax itself is divided into several spaces, and two of them are the right and left pleural cavities. They're separate from each other. The lungs don't communicate. That's why one can collapse and the other one can still be working. But we have true pleural cavities taking up a lot of space. And on the midline, we have a very odd anatomic structure containing many different things called the mediastinum. So, the mediastinum does contain the heart, but also a lot of other stuff, and it's more of a midline block of tissue that's in between the two pleural cavities. And with a little bit of a humble brag here, I just finished writing the chapter for the British edition of Gray's Anatomy on the mediastinum, so I feel like kind of an expert, and I don't want to bombard you with every little nook and cranny of details about it. So there we go, humble brag over. So if we were to look at the superior mediastinum here, what we have is an area from the sternal angle back to about the T4, T5 intervertebral disc. Now I should mention this whole thing from thoracic inlet down to the diaphragm is the mediastinum. And we divide it into superior and inferior mediastinum, mostly so that we can categorize the things that are in there. There's no real stop point visually separating the superior from the inferior mediastinum. It's just simply a little bit of convention for where that division happens between the sternal angle and T4, T5 intervertebral disc. What we care about, though, is that when you're doing a procedure in here, you're trying to watch out for, or maybe go in and fix, the large vessels. The superior vena cava, the brachiocephalic veins, and the arch of the aorta are all in the superior mediastinum. Our vagus nerve, our phrenic nerve, and our left recurrent laryngeal nerve are also in this area. So we have to watch for those in the locations they're at. The thoracic duct, bringing lymphatic fluid from the abdominal pelvic organs and lower limbs, passes through the superior mediastinum, as do the trachea, esophagus, the trachea and esophagus, as they're moving from the cervical region down into the rib cage, and in the esophagus's case, down into the abdomen. And the thymus, an immune structure, is going to be located anterior to the heart, and it actually does pop up just a little bit into the superior mediastinum. Now let's talk inferior mediastinum. As if dividing it into superior and inferior weren't good enough, the inferior mediastinum is divided into anterior, middle, and posterior parts, mostly for convenience of knowing what's there and what's at risk in various procedures. So the anterior mediastinum is easy. The thymus gland is there and not a lot else. There's some lymph nodes and some fat and connective tissue. The thymus gland tends to atrophy and get kind of a fatty infiltrate in it with aging, so that's easy enough. Middle mediastinum, it's all about the heart. So we've got the pericardium and the heart surrounding it there. The great vessels leaving the heart are located in the medial mediastinum, so the ascending aorta, the proximal part of the pulmonary trunk, and so forth. The arch of the azygous vein that's coming over to reach the superior vena cava as it comes towards the heart is in the middle mediastinum a bit as well. And the primary bronchi that are traveling down as the trachea splits will also be located in this middle mediastinum as they head off to the left and right lungs. Now finally, the posterior mediastinum is a weird space rather. It really extends really far inferiorly because its lower boundary is the diaphragm, and the diaphragm stretches really far down to T12 to attach to the vertebra. So we have this extended posterior aspect of the inferior mediastinum, and through that we have traveling the esophagus, the thoracic aorta, the azygous and hemiazygous veins. Remember, they were kind of right near the vertebral bodies. The thoracic duct traveling up from below to get to the superior mediastinum. Vagus nerve traveling inferiorly. They actually patch themselves onto the esophagus in this area. And then on either side of the vertebra we'll have the sympathetic trunk, and they're going to give off splanchnic nerves that are going to go to the various organs in the abdomen. More on them later when we talk about the autonomics related to the thorax and abdominal and pelvic organs. So I mentioned the thymus gland in its location in the superior, somewhat, and definitely in the anterior, inferior portion of the mediastinum. So as you've already heard, it's an important structure in the maturation of lymphocytes as they become T lymphocytes, and that's therefore going to be really strongly linked to our adaptive immune response. So it's mostly present in the anterior mediastinum and somewhat in the superior mediastinum. It's really pretty huge in children, and it tends to get smaller and atrophy a bit as we age, but it never completely goes away, nor does its function ever completely stop of getting our T cells able to respond to the challenges that our immune system is going to experience. Now right here, it's been removed, so we don't see the thymus here, but we do see the structures of the middle mediastinum pretty clearly right there. So there's the pericardium, not the heart, but the pericardium, the sac of tissue that surrounds and protects the heart. We have the left and right phrenic nerves traveling here, and they're being shown very clearly. They're actually kind of stuck within the connective tissue of the pericardium. So they're really, you have to shell them out of the pericardium's fibrous outer layer to really see the phrenic nerves that clearly. But the phrenic nerves coming from C3, C4, and C5 descending on the anterior surface of the anterior scalene muscle and crossing from the superior and middle mediastinum are the innervation of the diaphragm. So our diaphragm is actually innervated by C3, C4, and C5 by way of these phrenic nerves. So that's what actually allows our diaphragm to contract. The vagus nerve on the right and left are also traveling through the superior mediastinum. In the case of the right recurrent laryngeal nerve comes off and loops under the right subclavian artery to go up to the larynx. But on the left, it goes all the way down to the arch of the aorta before it returns up that way. The rest of the vagus nerve on the right and left side will then patch onto the esophagus, which is a bit posterior to what we can see right here. So there's the left recurrent going around the arch of the aorta. Next to the arch of the aorta, we have our superior vena cava, bringing blood from the head and neck and upper extremities, upper limbs, into the heart right there. Now here, we're taking a look at the heart in context right here with these other structures. We've opened the pericardium's anterior surface. That's what these little hooks are showing right there. So the pericardium, we'll talk a little more about it in a bit, but it's got two layers, an outer tough fibrous layer and an inner serous layer that secretes a little bit of fluid to lubricate the heart's motion. The left phrenic nerve, we can see still traveling along the outside of the pericardium to get to the diaphragm. There's the one on the right. Left vagus, giving off the left recurrent laryngeal nerve. Right vagus, and here the vessels are still intact in this image, so we've got the left brachiocephalic vein meeting the right brachiocephalic vein to form the superior vena cava. If I back up just a minute, we get our brachiocephalic veins from the junction of our subclavian and internal jugular veins. So subclavian vein plus internal jugular vein equals brachiocephalic vein. Right plus left brachiocephalic veins equals superior vena cava. Now, off the arch of the aorta, we've got three big branches. We'll see them as well. But right here, the first one's called the brachiocephalic trunk, and it's only on the right side. It's a big artery coming off the arch of the aorta, and it's going to give rise to the right common carotid artery and the right subclavian artery. So let's go a little further. We've taken the heart out. We'll come back to it. I'm going to spend a whole lecture on the heart. But now we can see the big vessels coming and going from the heart a little more clearly. And we've got the trachea present right here, and it's splitting to give off the right and left primary bronchi to the lungs. Now, left brachiocephalic vein, right brachiocephalic vein, still there. Superior vena cava is still there, even though we don't see it going into the heart anymore. Brachiocephalic trunk coming off the arch of the aorta right there. And now we're drawing attention to the left common carotid artery, and a little bit further this way, but coming off the aorta as a separate trunk, is the left subclavian artery. This illustration is making it look like these two branch off of each other, but they're separate branches from the arch of the aorta almost all the time. Now, a vessel we haven't seen before, this is the pulmonary trunk. Now, this is an artery, and the illustrators have shown it red because it's an artery, but it's actually taking deoxygenated blood from the right side of the heart, the right ventricle, and pumping it into the lungs, and then it's connected to the aorta by a little strappy ligament called the ligamentum arteriosum. Next, we have the pulmonary veins, which are bringing oxygenated blood back from the lungs to the left side of the heart, the left atrium. So again, the illustrator decided blue equals vein, but in this case, it's oxygenated blood coming to the left side of the heart. And right here, the trachea is located posterior to all these vessels, but its bronchi are splitting off and going to the lungs, and because of that, we can see the structure that's posterior to the trachea, the esophagus. So the esophagus comes into close approximation to the thoracic aorta here as they both head towards the diaphragm to pass into the abdomen. So there's the thoracic or descending aorta there. Now in this illustration, we've taken the heart, the lungs, pretty much everything out of the equation, and we can see the arch of the aorta, brachiocephalic trunk on the right, left vagus nerve right there, left recurrent laryngeal nerve looping around the arch. Here's that thoracic or descending aorta, and the esophagus. Notice that the esophagus is primarily midline, tiny bit to the right, but goes anterior to the descending aorta as it moves towards its entry into the abdomen through the diaphragm. The thoracic duct is usually visible between the esophagus and the aorta, very close to the aorta's right side. Sadly, in real life, it's not colored green. You have to look a little harder for it than that. And the trachea right here is splitting into the right and left primary bronchi that head off to ramify within the lungs to create the airway. On either side of the vertebra, connected to the intercostal nerves, we've got a nervous structure called the sympathetic chain. And the sympathetic chain is made from a collection of sympathetic cell bodies called because they're alongside paravertebral ganglia, and the paravertebral ganglia plus their little connectors are all called the sympathetic chain. There it is on this side as well. These give off a variety of nerves, and in this area we're just going to call them thoracic splanchnic nerves that are going to pass from the thorax into the abdomen. And what's interesting about these is that they're actually going to be innervating part of our abdominal organs, but they originate from way up here, about T5, in the thorax, and then pass through the diaphragm to get to the abdominal contents. So you got a slightly weirder picture now. This is a posterior view of the thoracic organs, the large vessels, the heart, the esophagus here. So we're looking at this from the posterior side, and in a bit of artistic license, there's no diaphragm separating the liver from the heart, so just be aware that's not accurate. But here we can see on the left the hemiazygous vein right there. That accessory hemiazygous vein would be joining it here, and the two of those join the right-sided azygous vein, which then dumps into the superior vena cava just before it enters the heart. Now we've got the right atrium, which receives deoxygenated blood from the superior vena cava, and our buddy the inferior vena cava here, which barely exists in the thorax before it drops into the right atrium. Then we've got blood pumping out of the heart's left ventricle through the ascending aorta, which we can't see here, it's anterior to all this, but then it loops over as the arch of the aorta to become the descending aorta there. Along the way it gives off the brachiocephalic trunk, which splits into the right subclavian and right common carotid arteries, and then separately we're going to have it's a little bit out of order, sorry about that, we're going to have the left common carotid and left subclavian arteries branch off, and they're going to be accompanied by the subclavian veins and the internal jugular veins on their respective sides. Now the airway here from larynx down to the trachea is present, but posteriorly we actually see the esophagus located posterior to it, traveling down, shifting a bit anterior to the aorta as it does so. And then anterior to the esophagus, there's the trachea and larynx splitting right here into a right and left primary bronchus. Lastly, from this view, we can see some of the pulmonary veins entering the left atrium of the heart here. There's a couple others sandwiched over here, but we're not seeing them as clearly, and they're going to be bringing blood from the lungs back to the heart. Now, before we leave the thorax, we need to talk about an organ or a structure related to the skin on the anterior thoracic wall, and this is the breast. Now, in a systemic anatomy course, we'd probably talk about the breast in response to its role with either the skin or the reproductive system. But since we're working through this in a regional way, the best place to talk about it is actually here with the thoracic organs. So the breast is actually a modified sweat gland that, instead of having a single coiled tube going down deep into the skin, has multiple branching tubes going down into the skin connected to the surface at the nipple, and those branching glands fan out into the underlying tissue and actually form multiple lobules. Now those lobules can produce milk when they get the right hormonal signals. So right here, if they are lactating, they become active and start shedding cells of the gland and the lobules into the area to create the milk. That's going to then travel upward to the lactiferous sinuses. Now I should mention this lactiferous duct, all these cells are present, but in a non-lactating individual, these glands will not be very active. Now, as they move through these lactiferous ducts, the milk can collect in small lactiferous sinuses that expand, and then those will all fuse to empty at the nipple, where a child can actually suckle and get the milk from the gland right there. Within the actual breast tissue, there's not just glandular tissue, there's also connective tissue and adipose tissue, and the suspensory ligaments of Cooper are connective tissue septa that they're shown here that connect it to the underlying fascia. Now, one thing, this image is okay, but it's not doing a great job of showing that all this stuff is actually overlying each other. There's not a fatty, fibrous part above and a glandular part below. It's all interdigitated together throughout the entire breast. The connective tissue structures that anchor the breast to the body wall are called suspensory ligaments of Cooper, and they're attaching to the fascia here, but they don't go all the way to the pectoralis major. There's actually a little space there called the retromammary space, or I've heard this too and I don't like it because it's not a true bursa, but it's called the retromammary bursa at times as well. But that retromammary space allows the breast to slide on the pectoralis major without becoming adhered. Now this becomes an issue when you have breast cancer. Okay, so there we go. The suspensory ligaments are right there, some adipose tissue in between. All right. Now, when someone has inflammation of the breast or breast cancer, the suspensory ligaments and that retromammary space can actually be clinically important to us. Swelling of the breast due to cancer or infection can cause those suspensory ligaments to pull little pockets of skin, little divots of skin in, causing what's called an orange peel sign, or in French is often how it's listed, the peau d'orange sign. But that's basically a sign that you've got inflammation of the breast as the suspensory ligaments are pulling on the skin. Now, just like lymph nodes can get stuck to the underlying connective tissue and become fixed when they get cancer cells dividing within them, breast cancer can actually spread within the breast and kind of violate the retromammary space and fix the breast and its connective tissue to the underlying pectoralis major muscle. So in this case, this woman's been asked to elevate her arms, and notice the right breast, in addition to looking a little bit inflamed, actually quite a bit inflamed, it rose up with the pectoralis muscle, whereas the one on the left, the unaffected breast, did not. So that's being fixed to the pectoral muscles by the tumor invading that retromammary space, and it's something that you can examine when someone is coming in and you suspect that there might be breast cancer involved. The vessels that supply the breast, we've seen both of them before actually. Largely, the breast is getting its blood supply from branches of the internal thoracic artery, which by the way is sometimes called the internal mammary artery for that reason. So there, we have some blood supply coming from the internal thoracic artery, but also from the lateral thoracic artery. We have that coming in as well. So lateral thoracic artery can also supply not just the serratus anterior, but also the breast, and maybe some lateral cutaneous branches at each level coming out with off of the intercostal arteries. So that's the blood supply to the breast. The venous drainage from the breast is actually pretty much exactly parallel. The medial side, blood will tend to drain to the internal thoracic vein, and the lateral superior side will tend to drain up through the lateral thoracic vein to the axillary vein here. Now, blood supply and venous drainage of the breast, that's important, but far more important, and we've discussed it a little bit already, is lymphatic drainage of the breast. So now we're going to talk about it in detail. It's important because carcinomas, or tumors that are from epithelial cells in origin, tend to drain through the lymphatics. It's their preference, and that's a common type of cancer to develop in the breast, and it can spread pretty widely due to the rich lymphatic blood supply in the area. So most lymph from the breast, about 3/4 of it, is going to drain superior laterally. So it's going to drain towards the axilla, so the area around the nipple, the areola, as well as the superior part of the breast, called the tail of Spence sometimes, is going to pretty much drain towards the pectoral axillary nodes. So those axillary nodes on the anterior side of the axilla. There's also going to often be some spread to these interpectoral nodes right there between the pectoralis major and minor, but the majority of lymph from the breast tends to drain towards the axilla. The remaining 1/4 of lymphatic fluid from the breast tends to drain towards what are called parasternal lymph nodes, which, like their name implies, are going to be alongside the sternum. Now, these are going to send lymph along something called the bronchomediastinal trunk that reaches the same place. All lymph in this area wants to get to the subclavian vein on the affected side. So whether it's draining medially through the bronchomediastinal trunk and parasternal nodes to reach that right subclavian vein, or whether it's going through the axillary lymph nodes, so intrapectoral, pectoral, central, apical, infraclavicular, supraclavicular, and boom, then finally to the subclavian vein on that side. That's the multiple pathways lymph can follow. And just to be extra maddening, lymphatic fluid doesn't play by any rules. Some lymph can actually go into the subxiphoid space and drain deeper along with abdominal organs. And sometimes tumor cells have actually been known to spread from one breast through these parasternal nodes to the opposite side entirely. So again, lymphatics have a tendency, but they don't play by any rules in any one particular case. So let's take a look at those axillary nodes one more time. The humeral nodes are on the lateral side. The posterior nodes, or the subscapular nodes, are there. Then we've got the pectoral and interpectoral nodes here. These are the ones that are more involved with spread of breast cancer from this lateral superior 3/4 of the breast. Now, once we're into the axillary system, the drainage can go to central axillary nodes or can skip them and go straight to the apical axillary nodes. But thereafter, infraclavicular and supraclavicular nodes tend to be involved, which are then going to dump into the subclavian vein there, either by joining the jugular lymph trunk or by forming their own separate lymph trunk and joining in there. Alright, so let's do some questions. Go ahead and pause, take some time to read it, and then I'll come back with the answer. Azygous and hemiazygous veins are going to be in D, the posterior mediastinum. Alright, pause, take a minute, read through the question. And now we're back. Answer is B, because the internal thoracic would be affected by that sternal fracture, but the rib fractures would also involve the intercostal vessels as well. Pause if you need to. And the answer here, D, parasternal lymph nodes, moving from the medial breast along the sternum to the bronchomediastinal trunk. Alright, take a moment, read through. We've made it through our first remote lecture. This is a little bit crazy, but I think we'll get better at it as we go along. And just remember to stay awesome. I think the world of you guys, and I look forward to seeing you next year.